always happen if it's the kind of incident that happen in someone's presence, is I think it's the kind of thing that you can assess immediately. But if it's not the one that happened in your presence, I think you shouldn't go because you don't know what happened. You get, but this scenario, this incident happened in our present, both at home or on the road. Okay, now Mrs. Joe was just walking on the road. All of a sudden, she slumped, and she slumped. We don't know what happened. As a nurse or as a helper, maybe you might not be a nurse, but as long as you have the idea of this CPR, you can go, you can do whatever you want to do to save that life. Are you getting me?
Yes, ma'am.
Are you getting me? Okay, now there are 7 steps.
Yes.
Okay, there are 7 steps which we do to help. 7 steps of this CPR. 1. Once you see this patient, this victim or this patient lying on the floor, the first thing we are going to do is what? We'll move out the patient from the danger zone. Let's assume the person was just moving on the way, on the road. All of a sudden, the person slumped. The person slumped, and you notice that, yeah, this person just fortunately slumped on the floor. And as a nurse or as someone that have an idea of CPR, you will know what to do. If the need is a free on the road, you bring the person out from the danger zone. That is the first step. Bring the person out from the danger zone. Because one, why do you do so? One, to prevent you yourself being a victim, and also to make that scenario to be comfortable for you. Am I understood? Can you answer me?
Yes, please.
Okay, the second one. Now, we've already moved out this Mrs. John out of the danger zone. Now, let's assume we have the head here of Mrs. Joe. Okay, we'll check for the airway. How do we check for the airway of this Mrs. Joe? Use your two fingers. See the way I positioned it. Can you see the way I position my finger? This is why I do my finger. Please answer. I will know that you are following me.
Yes, we can see.
I can see it.
Okay. You position your fingers on the person's nostril to check for what? Airway. Can you hear me? To check whether the person is breathing.
Yes, ma'am.
As if you want to this way. If the person is breathing a little. The second one, you check for the breathing side too. Airway, you can also check where if there's any blockage for the airway as well too. You check whether there's any obstruction, any blockage that person have. If there is none, okay, you go for the breathing. That is the B. Am I understood?
Yes, ma'am.
Okay, you check through your carotid. See the way I place my hand? Not mind my head. Yeah, this is your 2 index finger at the carotid pulse. That's for the breathing. Then you stand and look at the person's chest, whether it's moving. I'm looking at my Mrs. Jones' chest. If it is moving, can we all hear me? Please just I'm not talking to myself.
No, we can hear you.
Okay, so I'll look at my Mrs. Jones' chest. If it's moving up and down, that is for the breathing. Then the circulation, which is the C, there is a way that you know that there is no blood flowing. If the person starts turning bluish or gray in color, that means this Mrs. Jones, it has not enough blood circulation on his or her body. Am I understood?
Yes.
Step. Once you notice all this, and all of this is not where to be found, what are we going to do now? Now we'll start our chest compression. See if I position myself. Can you all see me? Can you all see me?
Yes, we can see you.
Yes.
I'll kneel down in front by the side of Mrs. Joe. Then see the way I place my hand. Can I place it this way or this way? Are you all seeing me?
Yes, ma'am.
Yes.
Then you place it at the left side of Mrs. Joe. The left side. On the base, the left side, the base breast of Mrs. Joe, the left side. Here. That is where the heart is located. Can you all hear me?
Yes.
This is
Yes, ma'am.
your hand. You place your hand this way at the left side. Then you give your 30 chest compression. Do you all hear me? Your 30
Yes,
chest
Yes.
compression. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, up to 30. Then your 2 rescue breath. Then how do we give our 2 rescue breath? You tilt the head up. Do you know why we do that? First and foremost, we check for the airway. Now we didn't notice any blockage. Now we tilt the patient's head up this way. Can you all see me do what I'm doing to myself? You can see me what I'm doing to myself. Just tilt the person's head this way. So that there will be the air. If you want to give your 2 rescue breath, the air will flow freely. There will not be anything like obstruction. But if the person's head is this way, the jaw and the rest of them will obstruct you. But to prevent all those things, you tilt the person's head up. Can you all hear me?
yes, ma'am.
Hello? Okay, now I've
We
tilt
can
my
hear you.
patient's head. After my 30 chest compression, we've done it up to 30 times. I give my patient 2 rescue breath. That way. Then you continue 30. Continue 30. But before you do that, make sure you send for help. Before you start all this procedure, make sure you send for help. Or you call for help if there's nobody for you to send the help to. You call for help or you send for help. Another ambulance or a nearby motor that will help you to move the patient to the hospital for further management. Am I being understood?
Yes, ma'am.
Now, 30 chest compression with 2 rescue breath. I'm giving my Mrs. Joan 1, 2, 3, 4. See the way I position myself. 3, 4. So you 2 use you yourself, you'll be comfortable. Then 2 rescue breath. And that scenario, if it's possible, you can wipe the person's mouth. But the person might be foaming. You can wipe the person's mouth with maybe the person's clothes. If you're not with your handkerchief, or the person's clothes or your clothes as well. Just wipe the person's mouth so that once you are giving the 2 rescue breaths, there will not be anything like obstruction. Am I being understood?
Yes, ma'am.
Okay, any questions so far before I'll go to my next one? There is much topic on this CPR, but because of other topics which you have at hand, I won't go more further. But these are the major ones which you can do to help out the patient from dying. Any question? Any question? You can ask me any question, or do we all understood what I mentioned, what I just said now?
Yes, ma'am.
Understood, ma'am.
Any question?
Hello, ma.
Yes, ma, I can hear you.
Okay, please, when you were talking about rescue breath, are you talking about mouth resuscitation?
I didn't get you. Say what?
You said after 30 chest compression, we'll give
Okay.
rescue breath. Is it mouth-to-mouth resuscitation?
Yes, mouth-to-mouth resuscitation. That's why I said you wipe out the person's, if there is any foamy something on the person's mouth. It's mouth-to-mouth rescue breath. Yeah.
Okay, ma, thank you.
Any other question? Okay, before I go to my question, I want to add something. You will continue this procedure until you get to the hospital. Even though you get help, you will continue with the procedure until you get to the hospital. Even though once you get to the hospital and they took over from you, please, though I think that then there will be oxygen and defibrillator there and the rest of them. But please, even though you're in the car with the person, continue the procedure until you get the help the person deserve. Am I understood?
Yes, ma'am.
Okay. So I want to ask, is there any question before I ask my own question? Any other question? Hello?
No
Okay.
question at your end, ma'am.
You said?
No question, ma'am.
Okay, no question. I assume that there's no question. Okay, I have my own question. I mentioned about 7 steps of CPR. Can someone tell me there's at least 1 or 2 steps that I just mentioned? I'm listening, no.
First, you
Hello?
remove the patient from the danger zone.
Okay?
Then you call for help. You
Okay?
check if the patient is breathing.
Yeah?
You can
She's not
start
telling
by
us, please. You're speaking
carotid.
to another person, please. Another person. I want to know whether we are following or I'm just saying, just talking.
I joined late though, but you mentioned mouth-to-mouth resuscitation.
Okay.
Um,
And the maximum process, I think I
30,
mentioned the number which you can give to the person.
32.
Okay. Yeah. Yeah, she's right.
And can I continue?
Yeah, sure. I'm listening.
Okay. You mentioned 30 compression at the left side.
Yeah.
Yes.
Yeah. If you're really following me, I'm so happy. Yeah, I'm really happy. Okay, now before I'll go to the next topic. This CPR have rules. Yes, they have rules, and the rules are ABC. There's some that you will see online, or maybe you heard from somebody. That is, I think, is what A, B, C, D. That D stands for defibrillation. That one occurs in the hospital. It's a machine on its own. So this ABC, I just bring it out because it's something that is just a first aid that we give to the patient before taking the person to the hospital. A stands for airway. B stands for breathing. Then C stands for circulation. I mentioned it in one of the steps of the 7 rules of the 7. Yeah, sorry, one of the 7 steps. Am I being understood?
Yes,
Are
ma'am.
you following me? Hello?
Yes, ma. Yes, ma.
Yeah,
Sorry, ma.
Okay.
I have something to say, ma.
No problem. I'm hearing you.
For those of us that joined late, please,
Is that
those 7 steps, can you just, ma?
I should repeat it?
Yes, just mentioned it for us, for those of us that joined late.
No problem. Number 1, remove the patient from the danger zone. That is the first step. Check for response. Sorry, I didn't mention that one. You check for response. You may be like calling the person's name or shouting the person. You say, hello, Mr. Hello, Mrs. Can you hear me? Can you hear me? Do you hear me? Then the third one is you check for airway of that patient. You've already removed the person from the danger zone. The second one is check for response, whether the person will respond to you. The third one, you check for the breathing. The fourth one rather, you check for the breathing. Then the fifth one, once you check for the breathing, you check for what circulation. done. Once all those things have been noticed, then you do your 30 chest compression with 2 rescue breath. Then after that, you repeat, continue the cycle. That is the 7th step.
Thank you, ma'am.
You're welcome. So now we all understood a little of the CPR, right? Little, but it's not all. These
Yes,
are
ma'am.
the these are the major ones. These are the major ones. At least what you can do to help the person before taking the person to the hospital. These are the major ones. Now we go back to our choking. We move back to choking. Okay, before then, why do we do this CPR? Let me put this my Mrs. Drum here. So why do we do this CPR? What are we trying to achieve? What's our aim or our purpose of doing this CPR? We said to enable to give oxygen to the lungs and also oxygenated blood all over the body. That is our major aim of doing this CPR. Now we go back to our choking. We go back to choking. We say, what is choking? As we all know what is choking. But we all know what is choking, right? Choking. Do you all know what is choking? Hello?
Yes, ma. Yes, ma.
Okay, they say it's the life-threatening caused by obstruction. This obstruction can be food, it can be an object. That is also medical choking. That maybe the person is unable to swallow thing. They call it dysphagia in medicine. Dysphagia. But our own meaning is something that is obstructing the airway. Something that is obstructing the airway. Now we go back to our practical aspect. I don't want to go deep down to theoretical when you're doing the practical aspects. In case if we're also doing this in case if we meet ourselves, no, maybe we have someone that is choking, or maybe someone that maybe in our home, God forbid, or outside, we can at least help out this person. We can help out this person to prevent the person from dying. Now, Mrs. Joe, this choking are in 2 ways. We can do it for the infant. We can also do this choking for adult and for child too. Infant, adult, and child. Child is different from infant. Infant is just that new baby they just gave birth to, or maybe the baby that is up to 0 to 1. Yes, those are the ones they called infant. Then from 1 to, let's say, to adolescent age, they are all called child. Then from 18 years and above, we call them adults. Now, choking, let's say Mrs. Joan swallowed, maybe she was eating mistakenly a bone, or how will I call it, something choked on her throat. And I'm there and I noticed that, yes, I can handle this. What will I do? The first one I would do, can you all hear me? The first thing I would do to this Mrs. Joe, which is adults, I'm talking about adults now. The first thing I would do to this Mrs. Joe is, one, there are 2 major ways which you can handle choking. One, for the abdominal tract, or the back stab, or the back blow rather. The 2 abdominal, this person is choking, and there are signs and symptoms, mostly the symptoms of choking. The symptoms of choking is, one, you will feel the person will find himself difficult to breathe. Like, let me say, I'm the person now that I think I have obstruction in my throat, and I want to bring it out. Well, the first thing I will do, I will head my throat this way. I won't be comfortable. I'll be finding a way to breathe. I'll head my touch my throat this way just for the stuff to come out. But no, it's not. The second one, I want to talk to somebody. I can't because of that obstruction. The third one, my skin will start changing color. Because once there is no air, once there is no free circulation of airway or the rest of them, the person color will start changing, either to bluish or to gray color. Now, these are the three things that you can notice. There's other things that you can notice. The person can be breathing, the breathing will sound like wheezy beat. That way, that sound that you'll be hearing, you know that the person is choking. So as a nurse or as someone that have knowledge of this choking, what are you going to do to this adult person? One, let me perform the first one. I'll help the person's, this is the abdominal throat. Sorry, let me remove this. This is the abdominal throat. This is the way I help the patient. Can you also see the way I help this patient?
Yes, ma. Yes, ma.
At the abdominal region. See the way I help the person. You give this way, your hand over this way, on that abdominal region. Then you give the person a heavy this way, like this. Just move the person. The person will be facing down this way. But sorry, my Mrs. Jones is not movable. So this person will be facing down. Assume that I am the person at the back, at the back of Mrs. Joe, but I'm facing down. Then I will use my hand to press the abdomen heavily this way. You do that about 5 times. Once you do that 5 times, then that is the abdominal thrust. Once you do this and the person is not responding, then we'll go back to our back blow. We call it back blow. But please don't blow this person. Don't blow this person or the person will not enter coma or something. But you can do your best. At the back of the person, this is the person, this is at the back here. Advice, we should use this here. Instead of giving the person blow that this way, use here instead. But there are some persons that have muscles. You might do, and maybe you might break the spinal cord or this bone at the back. But please use this. Can you also use here, this way, this particular your finger, but on this side. Use it at the back of the person. See where I put my hand. See where I put my hand here. Can you see? I put my hand on the person's abdomen here. Then I use my hand to hit the person at the back. But meanwhile, this person is already bending. Assume that this person is bending already. This way. The person is bending this way. Then you do this. You use your back and give the person 5 blows. 1, 2, 3, 4, 5. Can you all see it? Hello?
Yes, ma. Yes, ma.
Yes. So do these 2 methods frequently. Definitely one must help out for the adult patient or for the adult victim. Now for the adult and the child, you can do the same thing. Now for the infants, what is for the infants now? Okay, let's assume that Mrs. Joe is a little child. So let me look at this. Let me assume that Mrs. Joe is a little child. I want to sit down. Please help me. I'll carry Mrs. Joe like this. I'm facing Mrs. Joe at the back. This is for the infants from 0 to 1 year. So Mrs. Joe is facing backward. Can you all see me? Hello?
Yes, ma. Yes,
So
ma. Yes, ma.
Joe is facing backward. This is my baby. He's facing backward. Now I want to, and there's obstruction. I've noticed the symptoms of the signs and symptoms of obstruction. in this baby, that I noticed, even though not my baby, maybe my neighbors or the baby that I saw on the way, the baby is choking. Now, what will I do? I'll face the baby this way, then use one of my hand this and hold the abdomen. So once I do that, what I will do, I will use my two fingers. Don't use this, please, because their bones are fragile. Their bones are still tender. Please don't use this. Use your two finger and hit the back. Can you see me? You can see what I'm doing. Hello?
Yes, yes. Yes,
Yeah.
ma'am.
Put your hand this way, then use your two finger, hit the back, the middle back. Hit it 5 good times. If this baby is not responding, what you do, you turn the baby back. Then you give your baby chest compressions at the middle side, which is the left side, the base breast of the baby. You give with your two finger. 1, 2, 3, 4, up to 30. Then once you do that, you continue. Before you know it, the obstruction will come out. Am I being understood?
Yes,
Hello?
ma'am.
Hello?
Hi. Yeah, I'm with you.
Hello?
Hello, ma.
Any questions so far before I go to the pregnant and to serve, if you want to go for the pregnant woman or somebody that is chubby, and to yourself and to the person and to yourself instead. Any question? Any questions so far? Any question?
No question.
Or you want to understand what I just said?
Yes.
Okay. Now let's assume that Mrs. Joe is pregnant. Let's assume that she is pregnant and she's choking. I can't hear that. Let's assume that Mrs. Jones is choking, is pregnant, and so she's choking. You've already seen the signs and symptoms. Please, Amaka, please mute your mic. Amaka, mute your mic. So let's assume that Mrs. Joe is pregnant and she's choking. No, you know that we can't hold her on an abdomen. What we are going to do, we use at the breast side. This is the abdomen. At the upper side. We hold our Mrs. Joe this way. We're not going to do the abdominal thrust. Yeah, no. But we can do the back stab. The back blow rather. We can do the back blow, but not the abdominal thrust because of the pregnancy. Let's not harm the baby. So what we'll do, we'll place our hand below the breast bone of the patient. Now I'm placing my hand here. I'll just do this way. Then I'll give Mrs. Joe the 5 blow. With here, please. But if you know your hand is lighter, you can use your blow. But if not, please use here. Once you use here, at least the weight is a little bit reduced than the blow. So if not blow somebody, and the person will be. So just hold the person this way, the pregnant woman this way. Then you give a blow, 5 blow. You continue. The person is already facing down. Continue until the obstruction comes out. Same goes with the person that is chubby. Your hand cannot move. Let's say the person is fatter than you or bigger than you or something. Your hand cannot move close, like the way my hand is squeezed towards Mrs. Joe now. Maybe your hand cannot do that. You do this as well to that person. Am I being understood?
Yes, ma'am.
Hello?
We are with
Anyone?
you, ma.
Okay. Now, to yourself, because we too, we do choke. To yourself, if there's nobody to help you out, nobody that have the idea of helping you out, you can do it to yourself. Now, what do you do to yourself? What you do, you place, you can do this with the abdominal trust. This you're never here. You place, you make a feast, a little feast. If you're not having any abdominal issue, please, if you're not having any abdominal issue, maybe you just finish surgery or whatever, please don't do this. Can you hear me? Hello?
Yes, ma.
Don't do this if you have any abdominal issue. Don't do this. But if not, if you're okay, make a feast like this. Then give yourself. But before then, you're already facing this way. Give yourself a 5 blow. Open your mouth. Then do that severally. Or they said, or you okay, then you bend on a hard surface. Hey, I don't have a hard surface. You bend on a hard surface, on a hard chair. Now that you make this, or you bend on a hard chair, squeeze. Let me just use this Mrs. Joe as a hard chair. Or a hard table. You squeeze yourself. Chair is more preferable because chair, your hand can go there. You squeeze yourself. Make sure your abdomen is resting on that chair. Then you move. You move the chair towards you. Move it forcefully. Move it towards you. You can do this. You can do this severally before the obstruction will come out. Hello, can you hear me?
Yes, ma.
We can hear you, ma.
Okay, so any question before we go to another topic? Any question? Any question?
No question for now.
Okay, we all understood what I just described and what I just how will I put it? Yeah, described now. We all
Yes, ma.
understood, right? So
Yes,
if
ma.
we see a victim outside, we can help out with that person, right?
Yes, ma.
Okay. Now we go to dressing. Mrs. Joe, thank you very much. You've done so well. Now to our dressing. Are we seeing our items here? Our dressing items. Okay, I think I'll bring it up.
We can't see it too.
No problem, I'll bring it up. Okay, one. This is our first aid kit. And in our first aid kit, I think that's only the instrument that is inside there. These are our instruments. You can see my instruments now, babe. Hello? You can hear me? Can you hear me?
Yes, ma. Yes,
This
ma.
is called this instrument that I hold now. This is called a dissecting faucet. This is needle holder. This is a needle holder. To differentiate needle holder, you see there's a hole. Once you open it this way, there's a hole inside where you place your needle. So this is the curved artery faucet. This is curved artery faucet. Curved. Then this is scissors. So now I will join both incision and dressing together because they come together. After doing your drainage and incision, you go ahead with the dressing, right? So I will join the both of them together. First, let me start with the incision and drainage. What do you mean by this incision and drainage? Incision and drainage is where there is accumulation of pus. Maybe let's assume on the left leg there is pus. There is accumulation of pus. We all know what is pus now, right?
Yes, ma.
Okay, so there's
Yes,
accumulation
ma.
of
Yes.
I want to open this pus. Okay, now we opening this pus is called the incision. Cut. Cut means incision. In medical term, it's called incision. But in layman language, we call it cut. A cut. Now we want to inside this wound. I'll still carry my Mrs. Joe. Plus, it's going to be my patient. Now, I'm lying Mrs. Joe this way, and Mrs. Joe has a wound there. Can you not see what I'm doing?
No, no,
Eh?
ma.
Hey, well, let me
We
bring it
can't.
down.
I can't.
Let me bring it down a little. Can you see me now? Ooh. Sorry, I removed the picture. Sorry, I'm coming. Okay, sorry. But you can see me now. Can you see me now? Should I bring it down more? Can you see me? Hello?
I can only see you, but Mrs. Joe, I can't see Mrs. Joe.
Okay. I think I should bring it down. Totally.
It's better.
Like
Okay.
that.
Yes, Mrs. Joe now. Mrs. Joe has an injury on this left leg or this right leg, any of those. So now, this injury has already formed a big pause. And we want to incide this injury, we want to cut this injury. So now, uh, okay, that's what we call it um, surgical blade. It's not here actually, but we've seen surgical blade before, right? Hello?
Yeah. Yes, ma.
Okay, we call it surgical blade. We put the surgical blade on our spatula, or yeah, it's spatula. We put it in the spatula, or you can use it that way. You can use it. You first and foremost, you make sure that area is sterilized. How do we do that? We use our normal saline or our spirit to clean, or the Savlon, this spirit or the Savlon to clean that area first before doing anything. We can wash our hand or we wear gloves. But mostly, I think we should wear glove. If you can get glove anywhere, you can wear glove. Or if not, please wash your hand. Your hand must be neat as well. Then we use either these two solutions or the normal saline to clean that area. Not even that area alone. You can clean most of the areas around it, so that even if we are doing anything on that patient, there will not be cross infection. Are we all understood? Hello?
Yes.
Okay,
Yes, ma.
we've already cleaned this. We've already cleaned this. Now, some give a local anesthesia, but I think the best thing, because that place is already infected, the best thing for you to do, you give a painkiller instead of giving a local anesthesia around the surface. That is lidocaine. You give a painkiller. You ask the person whether is an ulcer patient. If not, please give diclofenac, or you give PEG to sedate the person because of the pain the person is going to undergo. So after doing that, you bring your surgical blade. You incide a little, not everything, just a little. Some use needle to incide, to cut. But the best thing, use if it's a big wound, if it's a big cut, use your surgical blade to incide a little cut. So once you do that, you use your two hands in pressing out with your gauze. This is our gauze, a sterile gauze, please. Use your gauze to clean. Once you are doing that, you are pressing it with one hand. You are using one gauze to bring out, to hold the the so that everywhere will not be messed up. I'm pressing this already. I'm pressing the wound already. Then I'm using this. See the way I place my hand? This is my gauze. I'm using this gauze to hold I'm pressing this the pulse. I'm using this to hold the drainage from not splashing everywhere. So once I'm doing that, I'll make sure all the pores are out. So how do we know that these pores are out? There will be other drainage, but once you notice a blood stain like not one. You notice the pulse is red. The pulse is whitish in color now, or let's say it's milk color in color, milk chip color in color. So in this aspect, we already after pressing our pulse, after pressing the wound, rather sorry, after pressing the wound, I will notice there is blood coming out, a fresh blood. But as there will be some that will mix with the pus. Please continue. Once you notice that fresh blood is already coming out, fresh blood, not mixed with pus, you please stop. Am I being understood?
Yes, ma.
So once we notice that, we use a light, we'll pack the wound. After that, we already will apply our solution. Some do apply a Providon after the wound. We'll clean it first with maybe with normal saline after everything, then use your Providon on the gauze or direct to the wound. Then you place it on the wound. You cover the pus. But once you're using your plaster, please don't make it firm. Let's say this is the wound now. I want to use my plaster. So because what am I trying to achieve? I want to bring out if there is any remaining pus, it will come out. Okay, let me use my plaster on this wound. You see the way I'm going to do it now. Now, I'll put this way and the second side this way, not too firm. I also in it.
Yes,
See the way
ma.
I put it, eh?
Yes,
So
ma.
if the drainage is coming to come out from this place, because there is no pressure holding it, I don't want to apply on the surface itself. So I don't want to apply plaster on the surface. So if the drainage is coming out, there won't be any obstruction for it not to come out. So this person needs to come for daily dressing. So there's some extent the person will come and they ask the person please not to come, or maybe alternate days to come. Are you getting me? There's some antibiotics that will be given to the person that will take care of the person. There's some pain relief as well the doctor will prescribe for the person to take after the incision and drainage. Can you all understand? Do you all understand me?
Yes, ma.
I think I've also mentioned about dressing in this incision and drainage. Firstly, what we will do, you wash your hand or you wear your glove. Secondly, you make sure the area is being sanitized. You sanitize the area. There's different ways of dressing. There are different ways of dressing. They have burns dressing. There's a way they handle burns dressing, the severity case and the minor burn dressing, and other maybe punctured wound and the rest of them. Then this drainage wound also. There's a way we do the dressing for each wound. Now for the burns wound, once we already clean the area with saline, with maybe not with spirit this time around, oh please oh, that body a burnt wound, don't use spirit on the person, otherwise then the person will fight. So don't use spirit. Use only a saline water, normal saline to clean the surface. If there is blisters, please burst that blisters. You can just give it a needle prick, then the blisters, you know what is called blisters?
Yes, ma.
So just give it a little puncture, the water will start coming out. Then after doing that, then you apply what they call, that is not here actually, Sofra 2. We apply it on the person. Some apply Damazine. So okay, these are Damazine here. We apply Damazine on the person's body. Then, depending on the severity of the burns, you cover it because of what infection. Light covering with your bandage or with this bandage, either of those. You cover it with your bandage. cover the area with a bandage. Then the person will come for daily dressing. So once the person is coming, if you check the wound that this wound is most healing, you can leave it open. Why are we covering that bonds? Because of cross infection. We don't want to do anything that will come, maybe the person will come back the next day and say, the wound have already escalated from how it was before. No. So to prevent that, we'll do what? We'll cover it with gauze. Please, we are not using iodine on these bonds. No, we can't. What you do, whether you use your Sofratu or your Damazine cream on this person, then other treatments might be required, other medications might be required. Are we all okay?
Yes, ma'am.
Any question? Any question before I go to suturing, which is the last one? Any question?
Hello, ma. Please,
I think
after after we've punctured the blisters, do we remove the skin surrounding the blisters
no,
too,
no, don't remove
or we
it. Don't
just
remove
puncture?
it. Don't remove. Just puncture.
Okay.
What we're trying to do is just to remove that accumulated fluid on that blister. Just puncture, little puncture
Okay, ma.
for those places that are blistered. Don't remove the
Okay, ma.
skin. Hmm?
Okay,
Any
ma.
other question? No other question. Okay. So now we'll go back to suturing. Now here is I will use Mrs. Jones this time around because Mrs. Jones doesn't have skin that I'm going to use for the suturing. Here is a skin. So I need to cut this. So I want to suture this patient. And before I go to that, sutures are of different types. Sutures are of different types. Some of us that are working in the hospital will know what I'm saying. Sutures are of different types. We have the absorbable and non-absorbable. Okay, so the absorbable ones are majorly used for surgeries, for maybe episiotomy tears, and some other areas which I'm going to mention. Now, the absorbable sutures are the Vicryz. The Vicryz. I don't know whether you've heard about it. They are the Vicryz, and they are of different sizes. The Vicryz are of different sizes. We have 2, 2O, 1O, 3O, 3, 4, 5O. We have of different types, and they are used for different cases depending on what you want to suture. Then now the non-absorbable ones are the chromics or the nylons or sleek. Please, are you hearing me? So this chromics, nylon or sleek, they are of different sizes as well. The ones that I just mentioned, they're of different sizes as like you can see nylon 1, you can see nylon 2, 2O, and then you can see chromic as well on that same sizes. So now this patient has a deep cut. This patient has a deep cut, or has a deep cut and a superficial cut. There are different cuts. Now, this deep cut affect both the derma and the subcutaneous. These are the skin layers I've just mentioned now. The two skin layers. There are three skin layers, but I just mentioned the two skin layers, which is the derma, the first one, this outer skin that we are seeing. Then the subcutaneous is after this derma. The subcute is under the derma. Am I being understood? Hello?
Yes, ma'am. Yes, ma'am.
Okay, now subcute. Now I want to suture this wound. I want to suture this wound. It's a big cut that affect the subcute as well. It cuts both the derma down to the subcute. Now I'm using my needle holding, and my hair is nylon though, but I'm going to improvise with it because we don't have Vicryz here. It's a non-absorbable. Now, the first one we're going to use for the subcute is the absorbable one, because we're going to close the derma as well, and we are closing the derma. We can't use the non-absorbable on this subcute. It's only on the derma we can use the non-absorbable. Now on the subcute, we are using the absorbable one, which are the Vicryl. I don't have it right now, but now let's assume I've already used my Vicryl. Let me put this so that we know how to put our needle. Your area must be sterile also. Sorry, I didn't mention that. Your area must be sterile. You must wear your gloves. See the way I place my needle? Your needle must be placed this way. I've clipped it. This is my needle. I've clipped my needle. Ready to suture. Let's assume we have both the absorbable and this and non-absorbable. Now we go down. We go down to suture with the absorbable one to suture the subcute. Now we've already done this. Can you see what I'm doing? Are we all seeing what I'm doing? Are we all seeing it?
Yes, ma. Yes, ma.
Okay, but you must make sure once you are bringing it out, everything is not going down. Then you bring out this. You use your. Sorry, I'm using my hand. You use one of your forceps, which is this. Use it to hold our needle. You can't use our hand because it's a sterile procedure. Use it to hold your needle, and you bring out your needle holding. Then you do this way. You roll your needle with your needle holding. You roll it. Are you all seeing what I'm doing? Then you pick the remaining one. Are you all seeing it?
Yes, yes.
We all can see it, Abby. I've already tied the first one. Let me come closer. I've tied the first one. Now I'm going to the second one. Let me hold my needles again. I've tied the first one. I can cut it if I want to, but if I don't want to, I will continue. Now I'm sewing my subcute though, mind you, I'm sewing my subcute. I'm not gotten to the derma yet. I'm still on my subcute. So now I've sewed the second one. Oh, sorry. Hope you all can see what I'm doing. What am I trying to achieve here? What am I trying to achieve? One, for quick healing and to prevent any vessels that have already cut. This one is for the deep cuts. Any blood vessels that have already cut, my suturing can prevent the person from having what they call hematoma, bleeding under the skin. Now, I've already done this severally. Let me just assume I'm done with it. Now, I'm bringing the stuff out. Then I'm going to use my non-absorbable for the upper side. Can you all hear me? Hello?
Yes, yes.
So now I'm bringing to the upper side now. I want to sew my derma I'm sewing my derma with the non-absorbable now, not absorbable one. Some use absorbable one, but once you use that absorbable one, before you know, the person will have a breakdown. The wound will break. So it's better you use a non-absorbable for the outer skin. Now, I've already done this. Okay, let me tie my skin. Let me tie the skin. I want to use it from that thing, so I don't want to cut it so it will not be short. So I've already tied the skin. Can you see it? I've tied it and I'm going to do it again so that the skin will not, the stuff will not lose. Can you see it? Can you all see it? Can you all see it?
Yes, yes, yes.
No. In this process, I'm going to cut it. Then do the same way I did this first one, the second one, the third one. If depending on the severity of the wound of the cut, please you do it to suture every damn thing. So once you are done with it, what are you going to do? We'll use can use your spirit to just damp it. Once you are done with closing the wound, to just damp it. Then use your Providon and your gauze to cover the stuff. Then you ask the person to come back in 7 days time for removal of stitches. Am I being understood? Hello?
Yes, yes, ma.
Any questions so far? Any question? Do I
As my
continue?
own. No, we can continue.
Okay, so now the places which absorbable sutures should be used, like I said earlier on, the outermost skin, like our upper limbs, now that is the legs and the arms. We use the outermost skin, for these non-absorbable ones. But for the inner skin, that you know that yes, once you cover, you can cover it back. Please don't use absorbable sutures. Use don't use non-absorbable, sorry, but use absorbable sutures. But the outer one, use the non-absorbable sutures for it. Now, during our episiotomy, use your once you're doing your, you know what is called episiotomy. That course we give pregnant women during childbirth. During that period, please use your absorbable, non-absorbable. No, sorry, your absorbable, because you can't ask the person to come back so that you start losing the suture. So please use your what? Your absorbable suture on that area. So the surgeons will use also, depending on the case of what they are doing, they will use, there's some that use non-absorbable though, but in my hospital, if it's doing a CS or any major operation, they use non absorbable sutures, not non-absorbable. Absorbable because to absorb on its own, except the person comes back again and the wound break down. They just only suture the outer skin. Am I being understood?
Yes, ma.
Okay, I think, is there any question before we call it a day? Any question? Any questions so far?
It's well understood, no question at my own end.
I can't hear you. Say what?
I said no question at my own end here.
Anybody, any question, please, you can ask, please. Any contribution, you can also ask. You can
Hello,
also ask.
please, ma, I want to ask question.
Okay, ma'am.
Please, you make mention of we have types of sutures.
Yes.
Sutures. You said absorbable and non-absorbable.
Yes.
Please, ma, which one is absorbable and which one is non-absorbable? Because me, I just joined the live now, not
Okay.
quite
Thank
long.
you. Just join the live now. I mentioned it. Okay, the absorbable ones are the ones that melt. I think I didn't mention that. I think I didn't mention, yeah, sorry. I think, but they are the ones that absorbable as it sounds, the one that can melt. Then
Like
the one that
what? Is
cannot
it
melt. Eh?
like examples? Maybe is it chromic one
I
or
mentioned,
stuff like
I
that?
mentioned ones. The absorbable ones are the Vicryls. Have you been
Okay.
hearing about Vicryls?
Yes, yes, yes.
Yes, those are the absorbable ones. Then the non-absorbable ones are the chromics, the nylon, and sleek too. They are the
Okay.
non-absorbable.
Yeah.
The
Thank you
absorbable
so
ones are
much.
they have and they are of different sizes. Okay.
Yes, ma. Thank you so
So
much.
any other question?
No, no, no. I
Hello,
don't
ma.
have.
The the non-absorbable the non-absorbable one that we use on the skin surfaces. Do
Okay.
we remove them after the wound has healed, or is it to
You
be
said,
permanent?
you said, I didn't get you.
The non-absorbable stitches, sutures.
Okay.
Do they remove them after the wound has healed, or it will be
Yeah,
permanent on the skin?
that's why I said after 7 days, you ask the person to come back to remove it.
Okay, ma.
Eh? Yes. So once the person comes back, and maybe there is breakdown, maybe the person poured water on it because what the things you're going to tell the person, please don't pour water on these sutures. They don't like waters. Once this suture is being covered with plaster and gauze, please don't pour water on it because once you pour water, to get to be moist, and once it's already covered already and you're still pouring water on it, there will not be air to dry the water, and once it's been moist, one, there will be infection, it will form pores, and once it's infected, this wound can break down. So once this person comes to the hospital after that 7 days and you still see a breakdown, you have no choice but to suture the person again. But please tell the person to avoid that. Tell the person, please don't apply water on this. Okay?
Okay, ma. Thank you.
So that is it. Any other question? Any other question before I call it a day?
Yes, I want to ask, after the,
No, I can hear you. Say what?
sorry, can you hear me now?
Yeah, yeah.
So I want to ask, after suturing,
Okay.
how often should the patient come for dressing, and what are we to
How often do
do
what?
in dressing? Should the patient be coming for dressing? You mentioned that the patient can come back for removal of stitches after 7 days. Now,
Okay. Like,
is it that the patient will just sit at home and then come
no,
back in
no,
7 days'
no,
time?
no. Depending on the severity of the case, of the wound. Let's say the one that I just mentioned now, the person have a cut from the cut starts from the derma to the subcute. In this aspect now, you will tell the person, please, in 3 days' time, please come, let's check it, you can dress it. So after the 3 days' time, you come, you open the gauze and the or the bandage or the plaster, open it, then you check if there is any opening, and if there is, you press it a little once, if there is any pause. We're just checking all these things. We're not removing the stitches yet. But we're just checking all these things to make sure that yes, this wound is still intact, is still okay. So what we're going to tell the person, you cover it back after you check, you cover it back with Providon and gauze. You cover it back. Then tell the person after that third day that the person came, tell the person in 7 days' time, from that third day, please come for removal of stitches. Okay?
Okay, ma'am, thank you.
Yeah. Any other question?
And let me also ask, ordinarily, what are we to?
I can hear you.
Can you hear me now?
Yes.
I want to ask, what are we supposed to clean the wounds with? Some
Is it
argue that methylated spirit is best. Some were
selling?
like normal saline is good. Some were like Uzor.
I can please
So
repeat the question. I can hear you.
can you hear me?
Yeah, I can hear you now, but please be loud
Did you
enough.
get my question?
No, 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 I didn't get it.
I'm asking generally, what is the
Okay.
standard solution for cleaning wound?
Okay, there are
Some were
different.
like methylated spirit is good. Some were like normal saline is the best. So that's what I'm asking.
Okay, the solutions that are good for cleaning wounds, and also depending on the kind of the wound and or the severity of the wound. Hmm? There are solutions of cleaning the wound. Maybe you ask this person to come back after 3 days. One of the solution we use in this is this spirit or saline because we've already covered this wound already. We use our spirit or use our saline to clean this wound. So once, because definitely the person will be like, "Ah, the spirit is paining." No, no, it won't pain because you've already covered the skin. So after that, you cover it with Providon. Hmm? Are you getting me? Hello?
Yes, yes.
But
I'm with you.
if
I'm with you.
but if it's like that drainage, drainage that we did suture, in that aspect, if the person comes for dressing, we'll notice that that place is already open. We didn't suture it at all. So the place is already open. What
Yes.
are we going to apply on this? We'll apply, see this sablon, please remove this. We'll apply this sablon on the
Okay, we
person.
clean with Savlon, right?
Eh?
We clean the wound with Savlon, right?
Yes, for drainage. For the wounds that are not sutured, you
Okay.
apply your Savlon or your Isol on that wound. Let's assume this wound, this drainage happens here. No, we didn't suture the drainage. We just left it open that way for other drainage to pass through. So now the person comes for dressing. We use this. Some use hydrogen peroxide on it because that wound there will be a little slough on it. Slough that is something that they call that is something that covered wound. It looks whitish. Some persons, like for me, if a patient comes to me, what I will do to the patient, I will tell the patient because it's painful. I will tell the person that what I'm trying to do now is to help the wound to heal fast. I will try and remove the slough, which is the whitish something there, because that whitish organ covers the wound healing. It covers it. So to prevent it, please tell the person that it will pain you, but please, this what I'm doing now will help out with your wound. You remove those slough gently. Then after removing the slough, you clean it with this, your saline or your Isol. Hmm? Some, after doing that, some they apply honey or this Providon. Then you cover it. Honey is also a best solution for wound healing. Are people all getting me?
Yes, yes, I get that. So
So
generally for burns and for dressing wounds like from abscess or a wound that has just been incised, it's best to clean with
Peter,
normal saline or Budol.
I can
I
hear
think for
you.
dressing, can you hear me? I think the network is bad where I am. Can you all hear me?
Yeah, I can hear you now.
Okay. I said now for wounds or that are being incised. So it is best to clean with normal saline or Savlon, right? And
Yeah,
then pack with
normal
Budol
saline
or
is
honey.
fine.
But if it's
To clean
infected,
the
we
wound,
can clean with hydrogen peroxide, right?
yes, normal saline is the best. Hydrogen peroxide is also best. Depending on the wound. For a sutured
Packing
wound, I
with
will advise you
honey
to a
or
sutured
Budol.
wound. A sutured wound, don't use those both the boats. Don't use it. For a sutured wound that you've not opened already, please don't use normal saline or hydrogen peroxide. You can use your spirits to clean to wipe out the surface. Then you cover it with your Providon. Hmm?
Okay, that's for social wound, right?
Yeah, for sutured wound. But for
Clean with
non-sutured wound, you can use
spirit.
your normal saline, your Savlon, your hydrogen peroxide, and the rest of the things. Hmm?
Okay, man. Thank you very much.
Okay. Any other question? Any other question?
When cle- when cleaning the wound, if it's too painful for the patient to handle, local anesthesia can be used, right?
When cleaning the wound, you can't use local anesthesia. Rather, you give the person maybe diclofenac, any pain relief. But please don't use local anesthesia on it again. Hello, have I answered your question?
Yes, I think you've answered the question. When cleaning wound, we are not to apply any local anesthesia. I understand that when dressing some wounds, maybe for instance burns, maybe all this second degree, third degree burns, at times it can be very, very painful.
Yeah.
So
You can give the person a sedative, like pentazocine. So
pentazocine. Okay.
while you are doing your thing.
Okay.
But please don't apply any local anesthesia, please.
Anesthesia. Local anesthesia is only to be applied when we want to
When you
suture,
are
right?
suturing, yes.
Or when we want to do incision and drainage,
Yes,
right?
yes.
Okay.
Incision and drainage, you don't apply local anesthesia on that area because the place is already swollen. So you can't apply any local anesthesia. Rather, you give the person the pain relief for incision and drainage. But the one that
Just make
local anesthesia can be applied is your suturing. When you are doing your suturing, you can apply your local anesthesia. Okay. Yeah, any other question? So can we call it a day?
Yeah,
Can
thank you so much, ma'am.
Thank you so much, ma. I really appreciate it.
You're welcome. You're welcome. Thank you all for all listening to me. I'm really,
Thank
really
you.
grateful. Thank you.
Thank you,
Goodbye.
ma. Goodbye.